Imagine a patient walked into a clinic, right? One week, they're complaining of severe localized joint pain. Maybe their knee is swollen.
Yeah, pretty standard stuff for a clinic.
Right. But then a few weeks later, they're back, and now their liver enzymes are just completely through the roof.
Which is definitely a major red flag.
Exactly. And then, like, a month goes by, and suddenly they develop a dangerous heart murmur.
Oh, wow.
Yeah. So, to an ER doctor relying on standard physicals, this looks like three completely unrelated medical crises. I mean, you might think the patient has rheumatoid arthritis, then hepatitis, and then some sort of sudden cardiac failure.
I mean, sure, that's what the surface level evidence points to.
But in reality, it is the meticulous work of a single microscopic mastermind that's just hiding in plain sight. Welcome to the deep dive, everyone.
It's basically the ultimate diagnostic nightmare. Because, in medicine, we're trained to look for Occam's razor, the simplest explanation that ties all the symptoms together.
Right.
But when a pathogen is literally designed to weaponize the body's own immune system, the simplest explanation is usually completely wrong.
Which brings us to our topic today. We are tracking down a pathogen so elusive and so perfectly adapted to throwing doctors off its scent that it earned the terrifying nickname, the Great Mimic.
Yeah, brucellosis.
Brucellosis. And what we are doing today is looking through a single fascinating source, an outline for a medical masterclass titled Unveiling the Great Mimic, a clinical masterclass on brucellosis. So our mission today is to unpack the blueprint of this disease.
And this is perfect for you, the listener, if you love those aha moments, but don't want to get totally bogged down in medical jargon.
Exactly, because this isn't just about memorizing symptoms. If you've ever wondered how doctors are trained to think when the standard x-rays and blood tests are actively lying to them, this is the pathogen that forces them to just rewrite the playbook.
Yeah, brucellosis forces a clinician to completely abandon the idea of a simple, clean diagnosis. You can't just look at the broken window, so to speak. You have to figure out the exact methodology of the burglar.
Right.
And to understand how this particular burglar operates, well, you can't start with the symptoms. You have to start at the microscopic level with this concept called intracellular survival.
Okay, let's unpack this, because the biology here is just wild.
It really is.
Usually when we think of a bacterial infection, we imagine like invaders storming the castle walls, right?
Mm-hmm.
The bacteria enter the bloodstream, they start multiplying, and then our immune system sends out the heavy artillery.
Specifically, these white blood cells called macrophages.
Right. The macrophages go out to hunt them down, engulf them, and destroy them.
Yeah, and that process is called phagocytosis.
Okay.
Basically, the macrophage essentially eats the invading bacteria and traps it in this sort of cellular stomach.
Like a tiny trap.
Exactly. Which it then floods with acid to dissolve the thread. I mean, it's highly effective for like 99% of the bugs you encounter in your daily life.
But the Brucella species doesn't play by those rules at all. When I was looking into its intracellular survival mechanism, the image that came to mind was a fugitive on the run.
Oh, I like it.
Right. So the cops are everywhere, searching the streets, shining spotlights in alleys. But the fugitive isn't hiding in an alley. They've actually broken into the police station, locked the door to the break room, and are just making themselves a cup of coffee.
Yeah, it is like a fugitive in a break room, but it takes it a step further. Because the fugitive is also forcing the cops to drive him to entirely new neighborhoods.
Wait, what?
Yeah. So when the macrophage engulfs the Brucella bacteria, the bacteria deploys this specific set of proteins that literally neutralizes the macrophage's internal acid.
Wow.
It just shuts down the cellular stomach completely. So instead of a hostile environment, the inside of the immune cell becomes this cozy, nutrient-rich incubator.
So it's actively hijacking the very cell meant to destroy it. That's terrifying.
Truly.
But wait, if the bacteria are literally hiding inside our protective cells, standard medical attacks, like, your everyday run-of-the-mill antibiotics, would be nearly useless, wouldn't they?
Exactly.
Because the medicine is looking for bacteria in the bloodstream, not inside our own white blood cells.
What's fascinating here is that you've hit on the foundational mechanism that drives everything about this disease. It's exactly why the masterclass emphasizes this before anything else.
Because it dictates the whole treatment plan.
Right. Standard antibiotics might sweep through the bloodstream and clear out the free-floating bacteria, which makes the patient feel better temporarily.
Right, they think they're cured.
But the drugs bounce right off the macrophage cell walls. The bacteria inside are completely shielded.
Wow.
And this single biological trait, the ability to survive intracellularly, is what allows brucellosis to transition from an acute sudden illness into a chronic, agonizing, lifelong condition if it's not caught.
So, knowing that it acts like this microscopic Trojan horse, kind of rewriting the biology of our immune system, the next logical question is how this infiltrator actually sneaks into the human population in the first place.
Right.
Because you don't just catch something like this on the subway because someone sneezed near you.
No, you absolutely don't. And this is where the detective work of diagnosing the great mimic begins, often before the doctor even touches the patient.
Okay, so where does it start?
It starts with a social history. Brucellosis is a zoonotic disease, meaning it spills over from animals into humans.
Got it. So the masterclass emphasizes occupational exposure and endemic regions. And if this is an occupational hazard, it implies that human behavior and our jobs are driving the transmission, right?
Yes.
We aren't just talking about office jobs, obviously. We are talking about deep daily interactions with livestock.
If we connect this to the bigger picture, the epidemiology tells the entire story. There are different species of Brucella tied to entirely different animals.
Like which ones?
Well, you have Brucella melitensis, which is found in sheep and goats, Brucella abortus in cattle, and Brucellosis in pigs.
Okay, so cattle, pigs, sheep.
Exactly. If a doctor fails to ask a patient what they do for a living or where they've traveled recently, they are operating completely blind. They might completely miss the modes of transmission.
So what does that exposure actually look like in practice? Are we talking about animal bites?
It's much, much more subtle than that. Imagine a veterinarian delivering a calf in an endemic region, say parts of the Mediterranean, the Middle East, or Central and South America.
Okay.
Or think of a slaughterhouse worker who's handling animal tissue all day. The bacteria is just waiting for a microscopic cut on a hand or maybe a splash into the mucous membranes of the eye.
Ugh, that's rough.
It gets worse. It can even be aerosolized. A farm worker sweeping out a barn can literally inhale the bacteria floating in the dust.
Oh, wow. But it's not just an occupational hazard for farmers and vets, is it? Because the pasteurization of milk plays a massive role here, too.
Yeah, absolutely. Unpasteurized dairy is one of the most common vectors globally.
Really?
Oh, yeah. Think about a tourist who travels to an endemic region. Maybe they eat this beautiful, locally made, unpasteurized goat cheese.
Right. Something very artisanal.
Exactly. And they just ingest the bacteria directly. The acid in the human stomach isn't enough to kill it, and it slips right through the intestinal lining into the bloodstream.
Where it is immediately eaten by a macrophage, it neutralizes the internal acid, and boom, the Trojan horse is officially inside the city gates.
Yep. And that's exactly why clinical training emphasizes patient history so heavily.
I can see why.
Because if a patient comes into a clinic in a non-endemic area, let's say a suburb of Chicago, with this bizarre array of symptoms, the doctor might never think of brucellosis.
But if they ask the right questions.
Exactly. If they ask, have you traveled recently? And the patient says, yeah, actually, I spent a month on a farm in rural Italy eating fresh cheese. Well, suddenly, the entire diagnostic landscape shifts.
Because without that context, the symptoms are just noise.
Just noise.
Because once the bacteria exploits those occupational or travel risks and enters the body, it begins its true masquerade. And this is where the disease earns its dramatic title.
The clinical manifestations. This is where a medical professional's ability to recognize patterns gets pushed to its absolute limit.
Here's where it gets really interesting. Because the bacteria is living inside the macrophage, and macrophages are basically the body's roving security patrols, right?
Right.
So the bacteria effectively has a free transit pass to the entire human body. It's using our own highway system. So wherever that specific macrophage happens to travel, that's where the damage occurs.
And that is the exact mechanism of the mimicry. Eventually, the bacteria replicates so much that it ruptures the macrophage that destroys the host cell and spills out into the surrounding tissue to infect new cells.
Which causes massive damage.
Massive localized inflammation. And the sheer variety of where this can happen is staggering.
Ugh.
Medical students are explicitly taught not to get tunnel vision because this thing can show up anywhere.
Yeah, it reads like a laundry list of entirely different diseases. Let's start with the bones and joints, the musculoskeletal involvement.
So this is the most common presentation. The macrophages settle in the joints or the spine. The patient experiences just agonizing lower back pain or sacroiliitis.
And to a specialist, what does that look like?
To an orthopedic specialist, it looks exactly like a herniated disc or severe arthritis, or maybe even tuberculosis of the spine.
Oh, wow.
Yeah, they might spend months treating the patient for standard back pain. They might prescribe physical therapy and steroids, which, by the way, actually suppresses the immune system and helps the Brucella bacteria thrive.
Wait, really? The standard treatment makes it worse?
Often, yes.
Wow, but then let's say the macrophage takes a different exit on the highway. It travels to the liver or the spleen.
Well, the liver and spleen act as these massive blood filters for the body, so they're natural gathering places for macrophages anyway.
Makes sense.
When Brucella sets up camp there, it causes hepatic and splenic involvement. The bacteria forms these intense inflammatory masses called granulomas.
Granulomas. Well.
Organs physically swell up. A gastroenterologist scans the liver, sees these abscesses, and immediately suspects a primary liver disease or even cancer.
So it's actively baiting doctors into tunnel vision, like a shape-shifting villain in a comic book. How can any doctor form a clear differential diagnosis when the physical exam findings point to literally any organ system failing?
It's incredibly difficult. And it gets even more severe when you look at the heart. Endocarditis.
Right, inflammation of the heart valve.
Yeah, endocarditis is the most feared complication, and historically, it's the most common cause of death in brucellosis cases. The bacteria hitches a ride to the heart valves and begins multiplying right there in the tissue.
Just eating away at it.
Exactly. It creates these vegetative growths that physically destroy the valves. So a cardiologist hears a murmur, sees the valve failing on an echocardiogram, and just naturally assumes it's a typical streptococcal infection.
And what if it crosses the blood-brain barrier? I read about neurobrucellosis.
Oh, neurobrucellosis is devastating. The patient presents with meningitis, maybe severe depression, cognitive decline, or even cranial nerve palsies, like maybe part of their face literally droops.
So a neurologist is now looking at what appears to be a stroke or some sort of viral brain infection.
Exactly.
So let me get this straight. You have the orthopedic surgeon looking at the back, the gastroenterologist looking at the liver, the cardiologist looking at the heart, and the neurologist looking at the brain.
Yes.
And none of them realize they are all looking at the exact same fugitive.
That's the tragic reality in a lot of cases.
Mm-hmm.
But tying it all together is the hallmark systemic symptom of this disease. Undulant fever.
Undulant fever. What does that look like?
The patient's fever rises in the late afternoon and evening, accompanied by these drenching, foul-smelling sweats, and then it completely drops back to normal by the morning.
Like a wave.
Exactly. This wave-like undulating pattern happens because the bacteria are periodically bursting out of the macrophages into the bloodstream, which triggers an immune panic and the fever, and then they hide inside new cells, causing the fever to drop again.
That is deeply sinister. I mean, faced with a pathogen that hides inside our own cells, rides our own transit system, and causes seemingly unrelated symptoms across the whole body, how do you possibly set a trap for it?
It's not easy.
Which brings us to the diagnostic workup, because a standard blood test clearly isn't going to cut it here.
No, diagnosing an intracellular pathogen requires an intricate, multi-layered net. You cannot rely on a single test. You basically have to build a preponderance of evidence.
So what does this all mean for the patient lying in the hospital bed? The first step is usually a blood culture, right? Like you draw blood, put it in a petri dish with some nutrients, and see if the bacteria grows so you can actually identify it.
This raises an important question, because while that is standard operating procedure, you have to consider the biology we just discussed.
Right. The bacteria isn't freely swimming in the blood. It's hiding inside the white blood cells.
Exactly. Or it's sequestered deep in the granulomas of the liver, or hiding in the bone marrow.
So it won't even show up.
Right. So a standard blood culture might come back completely negative. The lab calls the doctor and says, no bacterial growth. The doctor thinks, great, it's not a bacterial infection, and they look elsewhere, leaving the mimic to just continue its work.
So if standard blood cultures fail, the next tool they talk about is PCR polymerase chain reaction. And if I'm understanding this correctly, if the bacteria is locked inside the macrophage, PCR doesn't care.
Right. It's essentially chemically cracking the cells open to dust for the bacteria's DNA inside, kind of like dusting for fingerprints.
That is a perfect way to conceptualize it. PCR is incredibly sensitive because it's looking for the specific genetic footprint of the Brucella species. It doesn't matter if the bacteria is alive, dead, or hiding inside a host cell.
It just finds the DNA.
Yeah, it amplifies that tiny trace of DNA until it's visible to the lab. But even PCR has limits, right? Like if the bacteria concentration in the blood is super low because it's all hiding out in the spine. So you also have to use serological tests.
Serology is crucial here because rather than looking for the burglar itself, serology looks for the alarm system that was tripped.
Okay, I like that analogy.
It measures the antibodies your body has actually produced in response to the infection. And it's highly specific. It looks for IgM antibodies, which tell you if it's an acute recent infection,
Okay.
and IgG antibodies, which tell you if the infection has been chronically smoldering in the body for months or even years.
Wow. So you literally have to triangulate its position. You use the patient history to establish the motive and the opportunity. You use imaging like MRIs to find the physical damage in the spine or the liver. And then you use PCR and serology to definitively ID the suspect.
It demands an exceptional level of clinical discipline. But, getting the diagnosis right is only half the battle.
Oh, right, the treatment.
Because once you trap the mimic on paper, you actually have to eradicate it from the body. And the treatment protocols are, frankly, brutal.
I noticed that. The masterclass dictates that standard antibiotics aren't just discouraged. The medical community dictates strict World Health Organization recommended treatment regimens. It's highly controlled.
Very controlled.
Why is that? Like, why doesn't just a heavy dose of standard penicillin work?
Well, we have to go back to the break room analogy.
Right, the locked door.
Penicillin works by destroying the cell wall of bacteria as they replicate. But it cannot easily cross the fatty membrane of the human macrophage. It's like trying to shoot a water gun through a brick wall. The penicillin clears the blood, sure, but the brucella inside the macrophage is totally untouched.
So you think you're cured, your fever drops, your joint pain recedes, you stop taking the medicine.
And 2 weeks later, the macrophage ruptures, the bacteria spills out, and the nightmare starts all over again.
Oh, wow.
Yeah. That is the dreaded relapse and recurrence that makes brucellosis so notorious.
So how do you actually breach the brick wall?
You have to use lipophilic antibiotics. These are drugs that are chemically designed to dissolve into and penetrate human cell membranes.
Okay.
The WHO regimens usually require a combination of at least 2 powerful antibiotics, like doxycycline paired with rifampin, or maybe streptomycin.
Wait, why 2? Why not just one really strong one?
Because Brucella is incredibly adept at developing resistance. If you use one drug, the few bacteria that happen to survive will mutate and become invincible to it.
Right.
So you hit them with 2 drugs simultaneously, attacking different parts of their cellular machinery to ensure total eradication.
And how long does that take?
You don't just do it for a week.
Uh-huh.
The treatment lasts for a minimum of 6 weeks. And if there's bone or heart involvement, it can last for months.
It's basically a scorched earth campaign inside the patient's body. I mean, if this complicated treatment isn't managed perfectly, if the patient misses just a few doses, the mimic survives, adapts, and entrenches itself even deeper.
Which is why the prognosis relies entirely on the clinician's ability to manage the long game. They have to monitor the patient for months, watching the antibody levels drop, ensuring the heart valves remain intact, and just constantly scanning for signs of a relapse.
This really completely changes how you look at the muddy waters of a medical diagnosis.
Doesn't it?
We always want the x-ray, we want the clean break. But the reality is sometimes the thing you are looking for is actively trying not to be found.
Exactly.
Brucellosis earns the title of the Great Mimic through sheer evolutionary genius, neutralizing the macrophage, writing our own immune system to every major organ, and masquerading as a dozen different localized diseases. Unmasking it requires a rigid, multi-layered diagnostic workup and strict adherence to those WHO combination treatments just to prevent a relapse.
The clinical masterclass is essentially teaching doctors how to outsmart a pathogen that has millions of years of evolutionary head start. But there is a final piece to this puzzle that shifts the perspective from the single hospital bed to the entire globe. The notes explicitly emphasize prevention and public health measures.
Right, because if you can stop the occupational exposure, you never have to fight the Trojan horse in the first place.
Exactly. Pasteurizing milk, wearing protective gear in slaughterhouses, vaccinating livestock, these are the real weapons against brucellosis. But, consider the underlying premise of everything we've just discussed today.
Okay.
We've spent this entire time marveling at how brilliant this single pathogen is at evading detection, at perfectly mimicking other conditions and slipping past highly trained specialists.
Yeah, it's pretty mind-blowing.
If a pathogen like Brucella is this perfectly adapted to hiding in plain sight, to weaponizing our own biology against us, it makes you wonder about the broader landscape of infectious disease.
What do you mean?
Well, how many other great mimics are currently out there? How many unexplainable chronic illnesses, lingering autoimmune conditions, or mysterious organ failures are actually the work of pathogens that are slipping quietly through our public health nets, simply because we haven't yet learned to recognize their specific disguises.
Wow. That is a staggering thought. It really makes you realize that the medical textbooks aren't finished yet, are they?
Not even close.
There are still fugitives out there hiding in the break room, waiting for us to figure out they're even in the building. Thank you for joining us on this deep dive, and until next time, stay curious.